Hello, my name is Danielle Brandt, and I'm going to be presenting on direct access in physical therapy. So, some history about it. So, the definition of direct access is that patients do not require a physician referral, so they can go schedule their own services through a physical therapy clinic without needing to see a physician first. Nebraska was the first state to allow this in 1957, and it just became all 50 states in 2015 that have some form of direct access now available. So back when this all first started and they first started allowing direct access, there was kind of two big questions that people were thinking about in reference to it. So the first one being, are PTs qualified to treat without the direction of a physician? And a lot of research has found that malpractice suits have not risen since direct access began. So that shows that we haven't been like making more mistakes than we haven't been either with or without a physician referral. So those have been kind of the same no matter if they are direct access or not. And then another question that was asked was increase in costs potentially, and a lot of research has shown that actually is much more expensive to go through a physician first than seeking PT directly. So it kind of just goes back to increased visits, increased interactions with more professionals, leading to an increased cost. So those two questions have kind of been answered by all the research that, in fact, there is better to use direct access in regards to those. And then the APTA came out with their Vision 2020 statement last year, and that's just kind of where they would like PT to be headed, and kind of their statement as of 2020, which had 6 key elements. So autonomous practice, direct access, a doctor of physical therapy degree for practicing PTs, using evidence-based practice, practitioner of choice, and professionalism. Okay, so nationally, here's a updated map of the United States from the APTA that kind of just shows how states are governing their direct access care. So these red states, only 3 of them left, have limited direct access. So basically, that just means that they're very strict on which direct access or how direct access can be used. So it can be like diagnosis specific or just very limited in general, not used much. And then the purple states are direct access with provision. So Indiana being one of them, about half the states that either have some sort of laws in their state practice acts that either physical therapy working for a certain number of years, so they've been out working in the clinic or wherever for a certain number of years, get their experience up, or some states require a certain time frame or number of visits for an episode of care before that referral is needed. And then these blue states have unrestricted direct access. But overall, like I said, it started in 2015 that all states had some form of direct access, but overall it is very underutilized in the United States. Specifically in Indiana, we have in our State Practice Act that we can evaluate and treat for 42 days or less. And then once it gets to that 42 days, we do require a physician referral. So that can be a referral from a physician, a podiatrist, a psychologist, chiropractor, dentist, nurse practitioner, or physician's assistant. And then we also would need an order for a spinal manip or sharp debridement. And those can be from physician, osteopath, chiropractor, or for the sharp debridement from a physician, osteopath, or podiatrist. And then here's a little slide about why does it matter. So I'm giving you all these facts and stuff, but here's this big thing over here in this picture that just shows the cost of care for going to direct access is about half the price of going through a physician first and then to physical therapy, and the outcomes are the same. So that's the big underlying fact, is that we're decreasing costs and getting the same patient results. But some other things, building better relationships with healthcare professionals, more autonomy for physical therapists as far as clinical decision making, opens up the market for physical therapy. Again, we're getting rid of those unnecessary referrals and physician visits, decreasing cost, ability to add cash-based services. No data have been found that there's better outcomes when going through physician, and no data that direct access increases risk for the patient. As far as financial planning on the management side, some things to consider are insurance types. So which insurance has coverage for direct access and has direct reimbursement, because that's something a clinic is going to want to know and want to take into consideration whether they want to allow direct access. Also, ability to add cash-based services and a potential for adding liability or malpractice insurance. And then again, decision making for the management side of things. Again, it's underutilized in the US. So marketing is a big thing right now that the profession needs to get on top of, because it is not very well known that direct access is even a thing for physical therapists. So, and then some more things to consider. Could increase the liability of caring for patients without that physician oversight, although it's been shown that it has the same patient outcomes. Potential increased malpractice insurance. You could have an increased schedule because you'll have those physician referrals and direct access. So that's kind of something you need to take into account when making decisions for your specific clinic. Reimbursement differences as far as insurances, and then a different patient population can be seen as well. And then kind of the same things, policy procedures. Just like any policy and procedure, you have to identify the problems first and make those procedures and reevaluate as needed. And then specifically to direct access, things you need to be more aware of is when to refer out. So if you're seeing a patient that needs to be going to a physician for some imaging or for some other testing that's not within our scope of practice, we need to know when to refer out. And then when to contact those physicians if an order is necessary for specifically an Indiana spinal nip, sharp debridement, or if you're reaching that 42-day mark. And also something to consider is patient waivers, so that they know that they are in direct care of us and being able to rely on our clinical decision making to make those decisions for them without talking to a physician or without orders of physician. And that is all. Here are my references, and thank you very much.